Welcome to another EduMed video. In this video we'll be talking about the intensive care ward round and how to assess the circulation. We'll look a little bit about how to examine a patient, think about the monitors that are there and talk a little bit about cardiac output monitoring, consider the reasons for hypotension and the role of echocardiography. In terms of assessing the cardiac system, it's pretty similar to what you would do on the ward, but there are certain key things that are slightly different with intensive care. One of the key priorities with intensive care is trying to assess what the intravascular volume of a patient is. Almost every patient, by the time they get to intensive care and also within the first few days of the resuscitative phase of a disease, tend to have a lot of fluid poured into them. Just because that fluid is poured in doesn't mean that it comes out or that it stays in the intravascular space. In fact, if you have a look at most intensive care patients in the first few days, they start to become progressively more edematous. One of your main jobs as an intensive care doctor is to try and assess what the intravascular volume is. There are a variety of different monitors and things that we can use to try and help us, but really and truly the most useful thing is actually clinically examining the patient and assessing them from head to toe. You can look at all of the things that are outlined in this great little picture that's been produced by the nursing education consultants. But essentially, start off by feeling the hands. Are they cold or are they warm? Is the patient dilated or are they vasoconstricted? See where the warmth starts to come in the skin. If it's halfway up the arm, or is it at the wrists, or is it at the fingertips? That gives you an indication of what the flow through the body is. And really, on the wards, we think about blood pressure, but what we actually care more about is the flow that goes through into the lungs, into the liver, into the kidneys, and so on. So a really good surrogate for getting flow or cardiac output is by looking at the amount of urine that's produced. So even though we won't touch upon it that much here, it's a great thing that sits with the cardiovascular examination is looking at how much urine is produced. Again, in the intensive care patient, this can be quite difficult because some patients are so critically unwell that they then develop an acute kidney injury. And so even though you're getting good blood flow to the kidneys from a macrovascular level, the intrinsic kidney function itself has been deteriorated, partly due to renal dysfunction from interstitial infiltrates or from significant amounts of inflammatory mediators and cytokine response. Not to mention the drugs that we use to treat these patients, such as nephrotoxic medications like gentamicin and vancomycin, to name a couple. It is vital to listen to the patient's heart every single day. And the reason for this is that they have a lot of invasive lines in, and those lines can become secondarily infected and then seed infection onto valves. So something that should always be in the back of your mind is any new murmurs that are heard, could they be an endocarditis? And especially in septic patients with significant bacteremias, the risk of developing a endocarditis does increase. So listen at the 4 quadrants for the 4 different valves. If you hear any difference, then it may indicate that the patient is developing either valvular dysfunction because of the papillary muscles, if they, for example, have had a heart attack and blown a papillary muscle, or if they've developed a endocarditis. When assessing a patient and their cardiovascular status, we do use certain targets, and the general targets that most people have are targeting a mean arterial pressure of 65 to 80. You'll notice that we target mean arterial pressures and not systolic pressures. The reason is the mean arterial pressure is a much better reflection of what the perfusing pressure within an organ is. And so for most patients, between 60 and 65 is adequate. However, if the patient is known to be hypertensive, those organs might need a slightly higher pressure head to provide adequate flow through them. So if the patient's lactate is rising, or if the patient's developing progressive kidney dysfunction, It might be actually that increasing the target blood pressure from 65 up to 80 might improve those functions just by increasing the pressure head through those tissues that are used to a slightly higher pressure head. Generally speaking, we use a transfusion trigger of 70 for most patients. There's really good evidence that giving blood and blood products to patients can be harmful to them, and it increases the risk of infection, increases the risk of antibodies being formed, and so generally speaking it's not a great idea. And so for most patients we tolerate a HB above 70. Some patients, especially those with ischemic heart disease, we might aim for a higher one, but we take that very much from a patient-to-patient basis. Similarly, for platelets, they are at risk of developing spontaneous bleeds, especially when in the context of severe hypoxia, patients can develop spontaneous intracerebral bleeds. So we try not to allow a platelet count to drop less than 30. However, again, it depends very much on each particular patient. If you're doing invasive procedures, some of them do require a slightly higher platelet count, but certainly for things like lines, if they're done by experienced people, a platelet count of even 30 or below isn't necessarily a contraindication, but that is very much done on a person-to-person basis, based on the patient and on the operator, and also on the institutional policy, so always check that before doing anything. Arrhythmias are really common in patients on intensive care, and to try and manage those arrhythmias, the first things that you can do are really simple, and that is to give the patient magnesium. Magnesium acts as a membrane stabilizer, so try and aim for a high magnesium above 1.2 millimole per litre. The other thing that's really important that people often forget about, because it's not something that's generally looked at in general medicine and patients on the wards, is the ionized calcium. In order for smooth muscles, such as vascular endothelium, to contract, i.e. to have tone, they need to have calcium, because calcium is what triggers the muscles themselves to contract down. And so you need to have a high ionized calcium. And so if you don't have an ionized calcium above at least 1, you might find that your levels of noradrenaline are going up and up and up, or that they're just not responding to the vasopressors that you're giving them. And it might be a vasoplegia secondary to the fact that their actual ionized calcium levels have dropped. Now you might ask, why would your ionized calcium drop? Well, it can drop for a number of reasons. Some medications can chelate calcium. Also, if you give people blood transfusions, the citrate in the blood transfusion bag can also cause it. And some filters, if you don't replace the adequate replacement fluid, can cause low levels of multiple ions. So always check the ionized calcium. And if you're anticoagulating a filter using citrate, for example, again, it can cause a systemic low ionized calcium. So when you're assessing the cardiovascular system, it's worth just thinking about what these levels are. Two really important concepts that I want you to take away from this particular talk is what is blood pressure and what is cardiac output. Blood pressure is really simple. It is the cardiac output multiplied by the systemic vascular resistance. On the wards, we use blood pressure as a surrogate for cardiac output, but you can see here that actually the thing that we care about is cardiac output, the amount of blood going out into the different blood vessels and therefore into the different organs to keep them perfused. It's a really important equation to bear in mind, because actually you start to see where if you increase the systemic vascular resistance, but the blood pressure stays the same, and the common thing is you keep increasing up the noradrenaline, but the blood pressure is staying exactly the same, you have to ask yourself, based on this equation, what is happening? So, the blood pressure, let's say, stays at 60, and you're increasing up your systemic vascular resistance. You doubled it, you tripled it, trebled it, but the blood pressure stays the same at a map of 60. The only thing that can happen is that your cardiac output is dropping, because the heart is now having to beat against a much higher end pressure, because you've caused vasoconstriction of all the blood vessels. So be very careful if you're increasing the amount of vasopressor, i.e. noradrenaline, but the patient's blood pressure is not changing. What you are probably doing is dropping the patient's cardiac output and therefore causing worse perfusion of the organs, and you might well see that the lactate starts to rise up even more. So be very careful of that. It's also worth thinking about what the cardiac output is. Cardiac output is simply the stroke volume, i.e. the amount of blood that's ejected through each beat of the heart, and the heart rate. So the faster the heart beats, the more blood that comes out, and therefore the higher the cardiac output. You know intuitively that's true because when you go for a run, for example, suddenly all your muscles need that much more blood to go to them, your heart rate goes up. The other way that you can do it is by increasing your stroke volume. And the way that we do that in intensive care is that we either give fluid to fill the heart up a little bit more so that each beat gets that little bit more blood that comes out, or we increase the force with which the heart beats. How do we do that? Well, we use inotropes. Inotropes effectively make the heart beat that much stronger, and there are a variety of different ways that can be done. We'll talk a lot more about cardiac output monitoring and about how to manipulate cardiac output and blood pressure in other talks, specifically targeting that. But it's just worth having that in your mind. So what we really care about, rather than blood pressure for the most part, is cardiac output. And there are a variety of different tools that we can use to monitor cardiac output. Two very commonly used ones on the intensive care are something called a pico, which you can see here on the left-hand side, and something called a lidco. The way in which this works is gone into a lot more detail in my talks on cardiac output. However, essentially what you're trying to do is to assess the amount of blood that comes out with each beat. And so you can use what we call pulse contour analysis. So we look at the arterial line trace, and we can work out a little bit about how the heart is beating. And then we can use a tracer, and in the case of pico, we use cold saline. We push it through, and then we see how that thermodilution occurs over time in a sensor on the special pico analyzer, which is a femoral arterial line. And then we can try and work out what the cardiac output is from that and give a quantified result. With lidco, again, the majority of it works by measuring the arterial trace and then working out exactly what the cardiac output is. Traditionally, we used to use lithium as a dilutant, and we'd put this in and then we'd use that to get an idea of what the cardiac output is. And with either of these, you get a whole range of values. And I won't go through them here, but in my lecture on cardiac output monitoring, we'll go through all of them and what those values mean, and importantly, what it is that you're trying to aim for. Now, I said at the start that the most important thing is to try and work out intravascular volume. Now, the reason for that is what we don't want is to pour fluid into these patients unnecessarily. We said that they just accumulate all this fluid, and this fluid sits in the interstitium of all of the organs and cause organ dysfunction. But similarly, you don't want the fluid level to be too low, because then they'll be intravascularly deplete, they'll become hypotensive, they'll reduce their cardiac output, and therefore they'll get organ dysfunction. So what you need to find out is this patient fluid responsive? Are they euvolemic or are they hypovolemic? And we're talking specifically about the intravascular volume. Well, a really easy way to find out is by doing a straight leg raise. This is what the normal patient looks like on intensive care. They're lying slightly head up to prevent aspiration of fluid down into their lungs, and they sit like this. Now, if you hit the reverse Trendelenburg button, which is this one, so you're bringing them head down, what that'll do is bring the feet up. So all of the blood that's drained in the feet suddenly drain back and increase the volume in the intrathoracic region. And each leg depending upon how big you are, can hold between 500 mils and 2 litres of blood. And so by doing so, you can significantly increase the intrathoracic blood volume and therefore see if the blood pressure goes up or if the cardiac output goes up, or usually both. The brilliant thing about this is if you find that the patient's blood pressure doesn't change or even goes down because you've overstretched the heart, you can take that fluid away really easily by just sitting the patient up again. And therefore all that blood drains back down into the legs and pools there. So you can find out whether the patient is fluid responsive, but at the same time not give them fluid that you can't then take away easily. As I keep saying, the assessment of the cardiovascular system really boils down to one thing, and that is, do the patients have adequate tissue perfusion? And you can use a number of things to try and assess that. One is looking for cool extremities. If the patient's cold peripherally, it means that they're vasoconstricted. Either you're giving them too much vasopressor, or they just haven't got enough intravascular volume. Another nice way of trying to assess how much perfusion or flow they have to their peripheries is looking at the difference between the central capillary refill time and their peripheral capillary refill time. Poor urine output is a great indicator if you've got normal intrinsic renal function, because if you've got normal kidneys and you just don't drink anything for a whole day, you know intuitively that you just don't produce as much urine, and the urine that you produce is more concentrated, so the volume decreases. However, the slight proviso to that in intensive care is often these patients have multi-organ failure and they may have some degree of intrinsic renal failure as well. And so dropping in urine output doesn't necessarily indicate that the patient is intravascularly depleted, but it could do. The other signs of poor tissue perfusion are confusion, and it's a really sensitive marker of poor tissue perfusion, which is often overlooked, especially in intensive care where the patient may be sedated or there's so much delirium going around that people might just think that that's the case. But if you do have a patient who's delirious or who becomes suddenly more confused, always think about their intravascular volume. Are they dehydrated? Do they need some more fluid? And the blood test that we all look at is the lactate. Now, the lactate has got a great reputation from the Surviving Sepsis campaign, and people often use this as a marker of tissue perfusion. Be aware there are certain times where your lactate can be high, but it doesn't necessarily mean that you've got poor tissue perfusion, because you can get excess production of lactate. And a good example of that is if patients are on adrenaline infusions or on high doses of noradrenaline, they can often have a high lactate that's not necessarily dependent on tissue perfusion, but more related to the way in which you've got cellular metabolism that changes with those drugs. When you're assessing a patient from a cardiovascular perspective, one thing that you must not miss is endocarditis. It's very rare, but it does happen, and if it does happen, catching it early can be the difference between that patient requiring a valve repair and requiring months and months of antibiotics, and potentially not. Arrhythmias are really common in patients, and one particular arrhythmia that's very common in intensive care is AF. Be careful with AF, because if you've got a patient who's got a poor left and right ventricle to begin with, by getting rid of the atrial kick, which is what AF essentially is, you can drop your cardiac output from between 10 and 30%. And for you or I, that might not be a problem, but for a patient who's got an ejection fraction of only 10 or 20%, that can be the difference between maintaining an adequate cardiac output and not. And so these patients don't tolerate arrhythmias very well, and managing and preventing those is really important. Low ionized calcium is something that's often missed because it's not something that you'd routinely look at on a blood gas. But if you should always consciously have a look, especially if you find that your noradrenaline levels are starting to go up or the patient is becoming less responsive to vasopressor therapy. And the other thing to think about there is whether to add in steroids. Again, we'll go through vasopressor therapy in a lot more detail in a separate video. So in summary, it's really worth doing a thorough clinical examination. There are certain things that you really want to tease out, the most important one of which is what is the volume status of the patient? Do they need fluid or can we take fluid off them? All patients have too much total body water, but that doesn't necessarily translate to them all being intravascularly replete. They may need to have some fluid put into the intravascular volume because everything is just leaking out. You've got to look at each individual patient and make that assessment for yourself based on all the things that I said. The other part of cardiac output monitoring, which I haven't gone through in this talk, but will definitely be going through in others, is using echocardiography. Again, as a junior doctor, you're probably not going to be using echocardiography that much, but it is a really helpful tool at the bedside to measure cardiac output and also get a visual representation of what their cardiac function is like and thus what you can change and what you can't.